Welcome to the Deep Dive. We're here to pull off the key insights from complex sources. Today, we're getting into, well, a really intricate area of specialized reconstructive surgery. It's a field where, even the most precise decisions can spark quite a bit of debate. Okay, let's unpack this. Our topic today is alveolar cleft reconstruction. This is such a critical part of care for patients born with cleft lip and palate. We're focusing specifically on repairing that gap in the upper jawbone, the alveolar cleft, and the impact of this procedure. Well, it really lasts a lifetime.
It really does. And our goal for you today is basically to cut through some of the confusion and controversy that surrounds it. This deep dive draws heavily from a great review by Doctors Kelly Kennedy and Peter Larson. We want to give you a clear rationale for the different ways of doing things, helping you understand the what, when, and how of this really delicate surgery, and maybe most importantly, why it matters so much for these patients.
Absolutely, because as you'll hear, this isn't just about closing a physical space. It's about stability for the entire jaw. It's about future dental health, overall health, even how a child develops socially. So get ready for some maybe surprising facts as we explore the different viewpoints here. So to kick us off, maybe the most basic question, is grafting actually, always the way to go? I know there are some non-grafting options, maybe prosthodontics. What's the general feeling and why?
That's a great place to start. The general consensus really is that getting continuity back between those cleft segments using a graft, it just offers really significant advantages. It's much more than just plugging a hole, you see. It's really foundational. There are several key benefits that really impact the patient. First, you've got arch stability. Think of it like building a solid base for the dental arch. It stops the segments from collapsing inward, which is just crucial for orthodontics later on, makes everything more stable. Second, it's vital for dentition health. The graft literally creates the bone needed for permanent teeth, like the canine and maybe the lateral incisor, to come in properly. Plus, it gives bony support to teeth that are already next to the cleft, very important. Third, the graft restores continuity right at the base of the nose, the piriform rim. This supports the side of the nose, the ala, so that has direct aesthetic benefits, but also gives long-term support if they need rhinoplasty later. And finally, a lot of these patients, even after their first palate repair, still have little openings, fistulae between the mouth and nose. Grafting is a key chance to close those, and that helps hugely with hygiene, with speech less nasality, and maybe even cutting down on chronic sinus or breathing issues.
Wow. So, okay, it's clear the upsides are pretty massive, touching on structure, speech, health, just about everything. It's a really comprehensive fix.
It is. Which leads to the next question. If the goals are so important, how do we actually know if a graft worked? How do we measure success? And this is a big deal because the literature really stresses, we need consistent ways to measure success if we want to compare different techniques. And historically, that's been, well, a bit of a challenge.
Right. So Berglund and his colleagues, they came up with a way to sort of quantify it. It's a scale, categorizing grafts into 4 types based on how high the bone is at the crest of the ridge.
Okay. The Berglund scale measures that crest height. But is that like the whole picture for success? What about bone deeper down near the root tips, that apical bone? Does that matter too? That's a really sharp question. Yeah, there's definitely been a move towards recognizing that just measuring the occlusal height isn't really enough. If you want teeth to move successfully into the graft, or you need support for the nose, or maybe you're planning a dental implant down the road, you absolutely need good apical bone formation too, bone down towards the root tip. So yeah, modifications to measure both the top and the bottom height are seen as probably a better way to evaluate things now. And imaging-wise, while the older 2D X-rays, like Berglund used, they actually correlate pretty well with 3D CT scans for overall volume. Nowadays, for research, it's almost all 3D imaging, much more precise for quantifying. But for just, routine follow-up in the clinic, 2D is usually fine. You'd save the 3D for specific things, like planning an implant after the patient's done growing. But here's something fascinating. Even with all this tech, nobody's actually pinned down a specific critical volume of bone needed for a graft to be called a success. We still don't know exactly how much is enough.
Huh. That's really interesting. We're still refining how we even define success. Okay, but if Giroux deciding if it should graft has a pretty strong consensus, then the question of when to do it, that sounds like maybe the biggest controversy in this whole area. This is where things get really interesting, right?
Absolutely. Timing is huge, and it really affects the outcome. Our source material breaks it down into a few key periods. First, there's primary grafting. This is grafting really early, under 2 years old. Now, if it was done right alongside the lip repair, long-term studies showed, frankly, unacceptable results. Things like poor maxillary growth, a concave or dished-in face profile, more crossbites. That approach largely failed. There was a variation, doing it after lip repair but before palate repair. That has worked in a few specific centers, but only with a really detailed protocol, using a prosthesis, limiting the surgery. Those folks report no change in facial growth. But still, any primary grafting means multiple anesthetics, multiple surgeries for a tiny child. It's not right for everyone, and the success rates were lower too, like 40–55% in one study compared to over 70% when done later. Then there's early secondary grafting, say between age 2 and 6. The literature just doesn't support this timing. The results aren't good, so it's generally avoided. Which brings us to secondary grafting during the mixed dentition. This is typically between 6 and 12 years old, usually after the front permanent teeth, the central incisors, have come in, but before the canine teeth erupt. And this period, this is consistently pointed to in our source as the most ideal time.
Okay, the sweet spot. So what exactly makes that 6 to 12-year window so ideal? What's the thinking?
Well, there's a really solid rationale. First, after about age 6 or 7, major maxillary growth patterns are more established, so the graft is less likely to interfere negatively. Also, kids this age are usually much more cooperative for the necessary orthodontic work. You generally have enough bone available from donor sites. And interestingly, the erupting teeth themselves can actually help stimulate and improve the bone volume within the graft. And crucially, you're grafting before those permanent teeth try to erupt right into the cleft space, which helps save them. There were landmark papers back in the 70s by Boyne and Sands that really established this timing. The ideal candidate, usually 8 to 12 years old, with the canine root maybe half to two-thirds formed. Now, even within that window, there's still some debate, early, like 6 to 8 years versus later, 8–12. Some evidence suggests going earlier might help save the lateral incisor if it's present. And finally, there's late secondary grafting, so after age 12. This is generally discouraged. Why? Well, the outcomes are just less predictable, lower success rates on scales like Berglund's. You get less support for the teeth next door, higher chance of complications for the patient, and less chance of salvaging that lateral incisor. The only slight plus side is that technically you have more options for donor sites as the patient's older, but generally not the preferred time.
Right. It's clear there's a strong push for that mixed dentition window. But you mentioned individual factors. Even within that sweet spot, things can shift. Like, how does dental age versus actual age play in?
That's a really important point. A child's dental development when their teeth are actually erupting is often a much better guide than just their birthday. We look at milestones like those central incisors coming in. Then there's the whole issue of the lateral incisor. Is it there? Where is it? Remember, something like 35–60% of these kids are missing that tooth entirely. But if it is there, and it looks okay, grafting earlier might help save it, maintain bone width, maybe avoid needing another graft later for an implant. And interestingly, when it is present, it's often sitting distal to the cleft further back than you'd expect.
Okay, and what about things like a rotated central incisor? That's pretty common, right? How does that affect the timing decision?
Yeah, very common. And it can cause problems with cleaning or just how things look. Grafting before trying to straighten that tooth orthodontically is usually recommended. If you don't, the orthodontic forces could literally push the root right out into the cleft where there's no bone. So graft first, then align. We also have to think about social issues. That 6 to 12 age range is a big time for school and development. You want to time the surgery to minimize disruption. Maybe slightly earlier is better to get it done before things get too busy. The patient size and the cleft size matter too. For a smaller child with a really large cleft, maybe waiting a bit longer within that window allows for a bit more growth, makes the orthodontics easier before grafting. And of course, you have to coordinate with other needed procedures. Speech surgery, like a pharyngeal flap, usually comes first. Sometimes you can do minor nose or lip revisions at the same time as a graft or just before. And finally, the team dynamic itself plays a role. Different specialists on the cleft team might have slightly different priorities. The orthodontist might want early alignment, for instance, and that influences the overall timing plan. It's all about coordination.
Makes sense. It's a real team effort. So once the timing is sorted, the next big decision is, where do you get the bone? What's the source for the graft?
Exactly, and the source often depends on that timing decision. Like we said, for primary grafting, the rib is often used because you need a good amount. But since we're focusing on that ideal mixed dentition timing, let's look at the main options there. These are usually autogenous, meaning from the patient's own body. So the main contenders are the iliac crest, that's the hip bone, the pelvis. The big advantages here are you get a really large quantity of good quality cancellous bone, that spongy bone with lots of cells. Morbidity, meaning complications or discomfort, is generally low. And you can often have two surgical teams working at once, one harvesting the bone, one working on the cleft, which shortens the surgery time. Now, there are different ways to take it. A lateral approach might cause more issues with walking or pain afterwards, but an anterior approach, using a special splitting technique, seems to avoid growth problems or major gait issues in kids this age. It's a really reliable source, good for pretty much any cleft, especially the big ones or bilateral cases. The other main option is calvarial bone from the skull. Advantages. Usually less pain afterwards, the scar is hidden up in the hairline, morbidity is generally low, and if one team does both the harvest and the graft, it can be quicker overall. But the downside is you get less cancellous bone, less of that spongy diploic bone between the hard layers of the skull, so it can be less predictable, especially for bigger clefts. Success really hinges on getting that good diploic bone, not just the hard outer cortical bone. One study did show slightly lower success rates, maybe 80% versus over 90% for iliac crests, and, sometimes families perceive it as being riskier, even though studies show it's generally very safe.
Okay, those are the main own bone sources. But are there alternatives? Can surgeons use materials that aren't from the patient?
Yes, there are alternatives, and they come with their own pros and cons. You have allogeneic bone, which is bone from a human donor, processed by a tissue bank. The big plus. No second surgery site for the patient. And some studies showed decent success, comparable to using the patient's own bone in certain situations. But the healing is definitely slower because there are no living cells being transferred. It might be less predictable in really big clefts, especially if they connect to the nose or mouth. And there's always that theoretical risk, however tiny, of disease transmission, though screening is rigorous. Then you get into things like bone morphogenic protein or BMP.
Right. This is where we get into that cutting edge stuff, but it also brings up some interesting questions, doesn't it? What exactly is BMP?
So, BMP is basically a powerful protein that signals the body to grow bone. The exciting part is the potential to avoid that second surgical site completely. There have been trials comparing BMP, usually delivered on a kind of absorbable collagen sponge, BMPAS-CS, directly against iliac crest grafts, and they've shown pretty comparable results in terms of the amount of bone formed, and teeth seem to erupt normally through it. Now, the advantages for the patient seem pretty clear: potentially shorter hospital stay, less pain, no issues with walking or sensation from a donor site, no second scar, maybe even shorter surgery time. But, and these are big buts, BMP is currently FDA approved for some adult procedures, but not specifically for growing children undergoing cleft repair, so its use here is technically off-label, usually within trials. There's also a unique side effect: significant postoperative swelling, much more than with bone grafts, though it does go away on its own. And maybe most critically, that collagen sponge carrier. It has no structural integrity, can't physically support the base of the nose like a solid bone graft can. Oh, and it's extremely expensive. So despite the huge appeal of ditching the donor site, for now, autogenous bone, especially from the iliac crest, is still considered the gold standard. The cost, the swelling, the lack of structure with BMPAS-CS, there's significant hurdles.
That's a really clear breakdown of the material choices. Okay, let's switch gears slightly to orthodontics. Another area with some debate, I gather. Presurgical versus post-surgical expansion. What's the story there?
Yeah, another key piece of the puzzle and how it fits with the surgery. There are good arguments on both sides. For presurgical expansion, doing the orthodontic widening before the graft, which most authors seem to favor, well, the thinking is it's easier to expand the segments then, less resistance. It can give the surgeon better access to close the nasal floor during the operation. It might make cleaning easier afterwards, and maybe less chance of reopening any fistulas. Plus, in bilateral clefts, it can help reposition that front segment, the premaxilla, to get rid of a traumatic bite that could actually hurt the graft. The goal usually isn't perfect alignment yet, just better arch form. Though, you have to be careful not to expand too much if the cleft is already wide, because that makes the gap harder to graft. On the flip side, folks who advocate for post-surgical expansion widening after the graft is healed argue that the graft might consolidate better under that dynamic load. They also point out you have a smaller soft tissue defect to close initially, maybe it's easier to find enough bone, and perhaps a narrower gap heals faster. This can work well if the patient's arch form is already reasonably good before surgery.
Okay, so it sounds like both can work, and it depends on the specific situation. But you mentioned something earlier, a warning about moving teeth orthodontically before grafting. Can you unpack that a bit more?
Sure.
Why is that generally a bad idea?
Yes, this is really critical. Generally speaking, you do not want to be moving teeth adjacent to the cleft with orthodontics before the bone graft is placed and healed. Why? Because there's a very high risk of inadvertently moving those teeth right into the bony defect of the cleft. You compromise their support. Studies actually show a direct link between graft success and having enough bone on the backside of that central incisor before the surgery. The graft needs bone to heal to, it won't stick to a tooth root. And remember how we said that central incisor next to the cleft is often naturally tipped and rotated? That position actually helps keep its root surrounded by the available bone. If you try to orthodontically rotate or upright that tooth before grafting, you might actually push the root apex right out into the void. And again, that underlying bone defect is almost always bigger than it looks on the surface, so you can't rely on just looking at the gums.
That's a really crucial point. Don't move the teeth into the gap before you fill it. So very briefly then, what's the general approach, the surgical technique itself?
Right. Well, the ideal technique needs to tick a few boxes. Get a watertight seal on the nasal floor side, allow access to close any fistulas, preserve that good gum tissue, let you close everything without tension, and minimize scarring. The most common way involves raising flaps of gum tissue from the cheek side and the palate side and bringing them together. It's not perfect, can be tricky in really big clefts. You can get some minor issues where the incisions meet, but compared to other flap designs, it's generally considered the best overall approach. The basic steps are: carefully dissect and stitch the nasal lining closed first. Then, pack the bone graft material firmly but gently into the defect. And finally, bring the outer gum flaps together over the graft, making sure there's absolutely no tension on the closure. Post-op care is key too. Antibiotics during surgery are standard, but interestingly, continuing them afterwards doesn't seem to improve success rates. Diet is super important. Liquids for maybe 5 days, then soft foods. But the absolute key is no biting with the front teeth. Cut everything small, chew in the back. Any pressure on the front can cause the graft to fail, especially in bilateral cases. And then you wait. Need an x-ray confirmation, usually around 8 weeks, to show the bone is consolidating before any orthodontics can start moving those teeth.
Okay, wow. That's a lot of interconnected steps. So to help make sense of it all, our sources lay out a kind of systematic step-by-step path. Let's walk through that timeline for you, the listener.
Exactly. This gives a clear picture of the typical patient journey based on the principles we've discussed. So, step 1. Around age 5 to 6, the child gets an orthodontic evaluation. You're checking their cooperation, looking for arch collapse, any extra teeth, supernumeraries. Need good x-rays here, especially that special lateral oblique occlusal view to see the cleft well. Step 2. If there are supernumerary teeth in the cleft, they get taken out, either now or at least 8 weeks before the grafting surgery. Step 3. Orthodontic expansion, but only if it meets specific goals like fixing a traumatic bite in a bilateral case or correcting collapse that would make grafting difficult. Importantly, no attempt to fully fix a crossbite or rotate those central incisors yet. Step 4. The alveolar graft itself. This happens ideally between 6 and 8 years old, hitting that early part of the mixed dentition window. The recommendation here is using 2 surgical teams, harvesting iliac crest bone while the cleft site is being prepared. Step 5. Graft evaluation. About 3 months after surgery, another x-ray, that lateral oblique occlusal again, to check that the bone has consolidated nicely. Step 6. Now, if needed, you do the final orthodontic expansion. And now is when you can start aligning those permanent incisors, rotating them to their proper positions. Step 7. Later on, after the rest of the permanent teeth come in, conventional orthodontic treatment takes place. You also keep an eye on the canine teeth erupting into the graft. Some studies say maybe 30% to 70% need some help, like surgical uncovering, while others find most come in okay on their own. If they do need help, you use techniques that preserve the gum tissue. And finally, step 8. Dealing with missing lateral incisors. The usual approach is to create space orthodontically and plan for a dental implant later, rather than trying to substitute the canine tooth. This happens after all the orthodontics are done, after any jaw surgery if needed, and only once growth is complete. And this is important that grafted bone often shrinks a bit over time. So very often, another small graft is needed later just to build up enough width for the implant. Getting both the bone and the gums right is critical for a good aesthetic result there.
So we've really covered a lot of ground here on alveolar cleft reconstruction, from why it's so crucial, through all the debates about timing, bone sources, orthodontics, all the way to that step-by-step process. You can really see how this systematic approach, focusing on that mixed dentition sweet spot, aims for predictable, positive outcomes that genuinely change a person's life.
Yeah, and if we connect this to the bigger picture, it really highlights that while we have guidelines, gold standards, every single patient is unique. Their journey is shaped by their specific anatomy, their needs, and the collaboration of that whole multidisciplinary team. It just underscores this incredible dance between surgical skill and developmental biology.
Absolutely. And thinking about just how much planning and expertise goes into rebuilding this one small section of the jaw, It really makes you wonder, doesn't it? What other medical interventions, things that might seem relatively small on the surface, actually have such huge cascading effects on someone's entire life, affecting their smile, how they speak, even their self-confidence. It's just a powerful reminder of how deeply interconnected good medical care really is.